I'm delighted to say I've been joined by the Operational Director of Integration for Halton, Mr. Dave Sweeney. Dave, thank you for joining us today. Tell us a little bit about your role.
Okay, well, some people of the voluntary sector audience, I believe this is going out to, will remember me as the Operational Director of Partnership Commissioning. Partnerships meaning that it covered a widespread of commissioning responsibilities for the then Halton St Helens PCT.
Okay.
Which had mental health, learning disabilities, drug substance misuse, urgent care, a very wide remit. Following the health reforms and the new changes and the changes to the Primary Care Trust, I've been seconded into Halton Local Authority from the now clustered NHS Merseyside.
Okay.
So the PCTs, as you've learned from the previous blog with my colleagues Cliff and Simon, have come together as NHS Merseyside. So I've been seconded into Halton, into the local authority, to integrate and to work on an integrated model, to integrate the systems, be that the voluntary sector, the hospital trusts, our liaison with Warrington as much as we possibly can, and to bring the systems and to it's kind of almost a Kofi and Ann role. Really.
Right, very nice.
Yeah. It's hopefully to build relationships and make sure that people start to talk each other and work in a more efficient manner. Which this is that's pretty much it.
Great. Are you enjoying your new role?
It's great. Halton's great. It's always been good to me in terms of my previous role. I think the local authority is excellent. It's got some superb leadership in there.
Excellent.
And the new CCG, whilst quite embryonic, as you've seen from my colleagues before, has got some strong people and some real good ethics. And therefore, as my kind of passion, which is kind of health and well-being, it's in good hands. And I think we've got a long way to go. But I'm happy that the ethos is being pushed in the manner that I'm being used to. So yeah, it's great.
Excellent, and the ship's pointing in the right direction.
I think so.
Tell us a bit about your experience working with voluntary sector organisations. You hinted at that when you talked about your old role. Tell us a little bit about your experience.
Yeah, well, I mean, as going back quite probably 10, 12 years, I've always had the some lead, independent on which role I've had in health and well-being. And that was certainly the learning disability as way back when I was a community development worker, which was supporting people with mental health problems into work and into health orientated kind of into keeping themselves fit and keeping themselves more proactive and all the rest of it. And without the voluntary sector, that job would have been impossible.
Right.
So at a very early very operational age, and certainly in my career, I learned that actually to be linking and having a relationship with the assets that you have in your community is absolutely vital. And as I've moved up through the, I was going to say the slippery pole then, I want to avoid that, cut that out. As I've kind of moved through a more strategic kind of direction in my career, it's been exactly the same principle.
Right.
Where to embody anything around health and well-being and to truly get the community feel and the community aspect of what health means, it is the voluntary sector plays an enormous part.
That must have been tremendously rewarding work.
It's been fantastic. What you learn very, very quickly in the voluntary sector, especially when you commission the voluntary sector, is that you've got to be straight.
Right.
You have to be straight. You cannot. There's no point going out and saying that you're going to do something if you don't do it. Because one of the things the voluntary sector is extremely good at, they've got a very long memory, and because they've had to deal with the sticky end of if you like, funding and having to having to maintain their own presence. They're really kind of hot on these games, but they're also very hot on performance and performance management and performance managing themselves. So I worked very closely with Debbie Dolby. And myself and Dobby. Forgive me, Debbie. Not Dobby. Nothing like Dobby. Myself and Debbie. Formed a really good relationship in terms of how we would then stratify or put some strategy against the ethos of working with the local authority. Sorry, the voluntary sector.
And do you think voluntary sector groups bring something to the table that colleagues in statutory agencies don't?
There is no doubt. There is no doubt. I think without that, it would be a far different conversation. For example, statutory bodies have always been quite rigid in their approach. They've always been kind of centralised, i.e. government saying this is what we want to see. No better example of that than the National Service Frameworks for Mental Health. It was very rigid in its approach. However, wrapping the voluntary sector approach around that, it's far more flexible, it's far more community based, and it's real. It's what people use on a day-to-day basis to keep themselves healthy and themselves kind of active in the community. But that's all good and well. It's all kind of fine words, unless you put it into practice. So the work that I did with Debbie, and then obviously with Sally and all you good selves, is kind of trying to put some kind of safety net around that and trying to explain that in some kind of strategy and some kind of performance framework. Hence the STAR standards and the Evolve, and
absolutely.
The Here to Help. Which really in its aim, and I think it's beginning to kind of fall out of that now. The whole ethos was to actually explain to commissioners, and certainly now no more important than the clinical commissioning groups now, in terms of how important the voluntary sector is to their mechanisms and their daily commissioning life. But what the STAR standard did was put that was to demonstrate that this organisation, albeit how small or large in terms of the funding, can replicate that and can give that assurance.
And those projects, if projects is the right word, but they've been so beneficial to voluntary sector groups who, in a sense, don't know the lingo, so to speak, who didn't understand outcomes. They've not had to change what they were doing, they're just recording what they were doing a little bit better. And it's enabling them to explain to any funder or anyone who's interested in their group the difference they're making in people's lives. In terms of differences, the health framework, it's changing nationally and locally. Could you tell us what this means for the voluntary sector in Halton?
I can, and just going back to your last point there, which I think you articulated really well, is that it has helped. But what I can't take away is the fact that at the beginning of this, like anything, it was seen as additional work. But I think you've articulated well. What we wanted to do was make sure that you're actually you may be doing the Picasso, or you may be doing something all the old standard. Use that to get this standard together, because it's very health orientated.
Absolutely.
But it was work, and I do appreciate a lot of these people are volunteers. A lot of people are kind of working, a couple of days here and there. And initially it did take a bit of stick, and I will hold my hands up to say, I did say, trust me, this will work out in the end. And fair play to the sector. We've had nothing but kind of positive feedback, and the work ethic is fantastic. So what does that mean? What does that mean for Halton? Well, in terms of that commissioning role, you've had explained by colleagues that the new commissioning kind of format will be through clinical commissioning groups, and their local authorities. So as the PCT funding from Halton and St Helens, the PCT won't exist. It's actually come 2013, April 2013. As it stands, it's still a statutory body, but the CCT is moving in shadow form to the end of the PCT. So in terms of that funding, both for Halton and St Helens, work is going on behind the scenes to make sure that funding is moved into the safety of the local authority contracting. And work we are doing is to ensure that funding is ring-fenced for the voluntary sector. So whilst it's gone from the PCT to the local authority, what we want to do is put a piece of work around it that ring-fence that spend. So we can't be, there's no kind of immediate kind of danger to that funding. Now long-term, nobody can say what, in terms of what the long-term means. In the kind of short to medium term, we're putting a safety net around this funding so we can really start to explore the outcomes for the local authorities.
Which is tremendously reassuring, I think, because whenever there's any change, everyone's slightly gripped by a sense of paranoia. And you often hear on the Today programme people saying things about how GPs are only going to commission stuff that's going to make them money and all this kind of, whether it's accurate or not, I've no idea, but it is tremendously reassuring that steps are being taken to look after our groups. You might be a good example of this, or your new role might be a good new example of this, but the NHS and the local authority are going to be working very closely in the future. What will this look like in practice? And how will it impact on our sector? As a two-part.
Okay, well it's a really good question, and I'm kind of I mean, it's almost kind of finger in the air in terms of, you know, a time machine. But I think we've got a good idea that what we've learned from the good things from the reforms. The good thing from the reforms is that it is putting clinical commission at the forefront of those decision making, which I think is a really, really good thing. You know, not necessarily on record, not necessarily. I don't necessarily agree with that because I've read the health bill from cover to cover.
Wow.
But I don't agree with everything that's in there. But one, from a principally, the good thing that's come from the reforms is that clinical input. Now, what it's meant as well is that because of the public health transfer into local authority,
okay,
it means that the local authorities themselves have to think differently about what health and well-being means from a health perspective as well as a local authority perspective.
Right.
It also means that the clinical groups have to think far more in terms of what the changes means for the community. So it's no more around just commissioning for diabetes and a disease kind of model. The CCGs and the local authority and the public health body have to think more holistically around what health means from a community-based point of view.
Right.
So in comes the voluntary sector that says, well, actually, we've been doing this for years, guys. How do we input into your clinical decisions? And I think the input into the health and wellbeing boards, the far more input in terms of what Health Watch actually becomes or means in terms of its totality, links as it is now, and more at the forefront, rather than being someone who is commissioned if there are, you know, a few coppers left at the end of the year, we shall commission something into the the voluntary sector. Far more an intrinsic part of what actually the solution of that means. And I think we are definitely pushing towards that. You yourself, you've been part of the wellbeing practice group,
absolutely.
which is a new way of looking at things.
Tell us a little bit about the wellbeing practice groups, because they are a fantastic idea. Yeah,
I mean the idea is that we want very quickly for the CCGs have got an enormous piece of work now. The local authorities have got a huge piece of work in transferring all this work into something that's tangible. So actually, what we want to do is behind that we want to do something that's innovative and new, and so that all this change and all this people that, you know, change fatigue that people are going through, they can actually see something formidable that they can hang the hat on and say, I've been part of that. Wellbeing practice in itself is not a new model. It has been. There are theories around this that have been throughout for the last 100 years actually. The principle is that we will pick a number of, through a criteria process, pick a number of practices that have come forward in Halton, and move towards a theoretic basis of a well-being practice. So actually the strapline being that you go to your GP to get well, but you go to your practice to stay well.
Right.
We know that the GP practices aren't going anywhere. They're a fulcrum to the community.
Of course.
They're a hub to the community.
Yeah.
And predominantly the people who go to the practices. I mean, I haven't been, touch wood, I haven't been for some time now, which means that I'm hopefully keeping myself fit. You know, drinking is a safe level.
Yes.
All the stuff that kind of, you know, we're sick and tired of actually people telling us to do.
Yeah.
But there are a number of people, a huge amount of people who do visit the practice on a regular basis, who perhaps don't get that opportunity, would benefit from something that would be easy and accessible through the practice. But actually, more importantly, we're going to change. This process is going to change the culture of that practice. We're hoping that each consultation with the GP is very different. It's far more positive. There's access to art while you wait. There's music in the surgeries. We've got there is a huge amount of evidence around green space. The theory being biophilia. So we're putting greenery in the practice.
Lovely.
No more kind of old leaflets, floppy leaflets that are hanging about. You know, we want to change these practices to be much more of a community base.
Right.
So the GP can say at any point, and this is where the work around. I'm really going on now. You've asked me a question.
Please. It's all good stuff there, so carry on.
They're here to help.
Yeah.
So if that was accessible to each and every GP as an icon on their PC, somebody's in front of you, you're in front of me. Now I haven't seen you for a while.
Yeah.
The consultation is different. Let's not concentrate on your chest infection where you need to fix that, but actually What are you doing in your community? Are you getting about? Are you exercising? Yeah. And then if the question is no, not as much as should be, there's a printable. This is what's going on. There's a monthly printout of what's going on in the community, so people can tap into that.
Fantastic.
We want to measure it. This is the important thing. We want to measure We want to measure the well-being of the individual that's going into the practice.
Yeah.
We want to chase that up, kind of 8 to 10 weeks down the line to see what that consultation meant to the individual and what the outcome was.
Okay.
But also, and as equally as important, we want to test the well-being of the practice themselves.
Right.
The GP, the receptionist. By doing this, by putting these different changes, this culture change in, do people enjoy coming to work now? Do receptionists see less aggressive patients in that can't get an appointment? Is there an alternative to the appointment? You know, that kind of thing.
Because it must be a heck of a job, I always think, being a receptionist and a GP.
Oh, there are some, there are some tough receptionists, I'm sure.
Oh, gosh.
I'm sure we've all come across them.
Absolutely. One of my best friends is a GP, actually. Now, I won't name him because he'd be mortified. But he's often said that one of the problems facing him on a regular basis is that he sees the same faces over and over and over again. All different, some young, some elderly. And I was saying to him, well, wouldn't it be great if you could send them out not to be beneficiaries of a voluntary organisation, but to actually join in and do some volunteering? And he thought that was kind of exciting. So I think it's especially with wearing my volunteer centre hat, I think it's exciting as well for a source for our groups to pick up some new volunteers who want to make a contribution in the community. I'm sure you're right.
I mean, there has to be to sustain this.
Yeah.
To sustain this, and it's not necessary. We will need volunteers. We can't sustain people going in working into a practice.
No.
Orchestrating art classes while people wait.
Cool.
It would cost an absolute fortune. So again, this is the power of the sector, power of volunteering. The volunteer will get as much out of being part of that practice's changing ethos as much as the people benefiting from that. So we know that, and there's this is not about kind of redesigning what volunteers do. We know why people volunteer, and let's tap into it. Let's not abuse it. Tap into it and use it as the amazing kind of health outcomes it has.
Wonderful. One final question, going back a little bit perhaps in terms of the conversation we've been having, but voluntary sector organisations having a look at the Healthy blog today, especially the smaller ones that have had no interaction, for want of a better word, with you guys in the past. They think being commissioned sounds wonderful, but what do those groups need to do to be ready to be commissioned? Yeah.
If I was accountable for an individual, as GPs are, i.e., I come to a practice with a problem. The problem's fixed, but actually the GP thinks, he or she wants me to do, you need to do a bit more exercise, your blood pressure's up, or so. But that person's accountable. That GP is accountable for the health of that individual. Okay. Now, what referrers won't do, and have never done, and I think this is where we're starting to really tap into this, is they won't refer on to an organisation that is not trusted, is not known,
of course,
is going to pose any risk in terms of that health, the health of that individual.
Well, they're responsible for that referral.
Exactly. So we know those that have been in the sector, work with the sector. We know that the vast majority of charities in the voluntary sector organisations do an amazing job. It's proving that, and I think through the STAR standard, and I think being as we evolve and become more around the practice, around the hub of that of the practice, and ensuring that the opportunities for practices to understand more what the sector does, as well as the STAR standard, as well as the Here to Help and all the rest of it. I think the lower end of the vol sector, somebody who's gone in, has an experience of mental health, gone away and trained themselves, and wants to run a befriending peer-to-peer group. Let's support those individuals to be, to do exactly what they wanted to do. I think in the past they've been missed. I think in the past we've slightly ignored that kind of the lower end. But there's a real opportunity to do something very different.
Brilliant. Dave, thank you so much for your time today.
Welcome.
Any other business, any messages that at this moment in time you'd like to get out to the sector, or do you think we've covered it all nicely?
Well, I think there's probably there's one key message, is to kind of just stick with it at the minute. You know, there are enormous amount of changes. I'm sure that everybody's, as I am, as everybody is in the health world. Stick with it, do what you do best, and you know, and work with us. Be open, be flexible as you always are. And this is the strength. It's build on the strengths, and somewhere down the line, I'm hopeful this is going to make some real sense.
Brilliant. Thank you very much for your time today.
You're very welcome.